For the panelists, you may proceed to go here at the stage. So for the first panelist, it would be Almira Sulaiman from the Department of Health, Soxargen region, the HIV program and rabies program manager. Nina Castillo Carandang, the Professor of Health Sociology and Global Health at the Department of Clinical Epidemiology of the College of Medicine of the University of the Philippines, Manila. Johan De Leon, the Volunteer People and Culture Officer of the HIV and AIDS Support House, or HASH. And Dr. Marvin Natural, the Clinic Manager and Primary Care Physician at MediPrime Medical Clinic, an HIV primary care facility in Cainta, Rizal. Ayan, may we invite the panelists to join us? Ayan. Again, if you have any questions that you want to ask in the panel discussion in the Q&A session, feel free to scan the QR code at the right side so that you could ask your questions. So, okay, before we proceed to our panel discussion, kakamustahin ko po muna kayo. Gising pa po ba kayo? Matitindi daw po yung mga questions, feeling ko. Feeling ko kayang-kaya nyo naman sagutin itong mga to. Ayan. Sige po. But I guess we'll start my first question to Shoshena. Shoshena, can you still hear us?
I can hear you. It's getting broken in between, but I can hear you.
Okay.
Yeah.
So I'll try to speak slowly for you so that you could understand me. Okay. So coming from your presentation of providing the guidance, the guidelines for PrEP and PEP, what are the best practices or successful models from other countries that can be adapted to improve differentiated delivery of HIV combination prevention here in the Philippines?
Can you hear me?
Yes, we can hear you.
Can you hear me?
Yes, Shoshena, we can hear you.
Okay, okay. You know, I must tell you that your country is one of the leading examples in the region. So, and that you should give a pat on your back that you have been doing extremely well. And I was also looking at the last year's data. Your PrEP use has, gone up quite a bit. Almost doubled from the previous year. But having said that, I don't want to say of any pre-prescribed model, because I understand that the reason you are doing so good is because you know what works in your context, and that's how you have been adapting the models accordingly. You are one of the groups who have been already taken up the DSD from pretty early on. So while those are happening, but one of the things I also want to say is that if the idea is to actually increase access to and utilization of PrEP, then we need to look at it, what are the barriers, and address it accordingly. We need to look at it, the groups who are actually not being provided till now, and what will make those group access and utilize PrEP. So I think it's more about what works in your setting, because we all know what kind of models exist. We know there are models, for example, tele-PrEP. We know models like, community-led PrEP has been already proven extremely successful. So there are things like that. I don't want to repeat around those things. There is a model, I think Malaysia is doing a pilot on pharmacy PrEP in the region. That's great. One of the things Cambodia is doing is also, as a process of their STI PrEP integration, they're also offering PrEP through the STI service providers. So, so there are things like that, but I think it's all about looking in your context, looking at the populations who are left out, and what are the barriers, and then how do you address it is the key. Thank you.
Thank you so much, Shoshena. I completely agree that comparing ourselves from the demonstration project where we started PrEP in 2017, we had a long journey already, and I think we still have a long journey to go because as presented earlier, we have a PrEP target of achieving at least enrolling 150,000 people in the next 3 years. And I think for us to
Yes.
enable these methods, I think the policy should, support all of these innovations. And with that, I would like to turn in the question to Doc Nina, because Doc Nina, you were included in the policy review that will suggest changes to our current interim PrEP guidelines, and eventually also the inclusion of post-exposure prophylaxis in our national guidelines. So if you can share some of the findings that you found in this review, including the findings that needs to be highlighted and be remembered by the people in this room.
Magandang hapon po. I'm speaking here in my personal capacity. I'm careful about that because this is a commission work by WHO. Okay, so I'm speaking as Nina and not organizational representative. So we looked at the current limitations of the HIV PrEP and PEP program. So we lack guidelines for non-occupational PEP use. We also have only oral modalities available so far. Our supplies mostly come from our development partners, and the PrEP programs are largely donor funded. So the availability and access to free HIV PrEP and NPEP are limited to 10 out of the 17 regions. So where is equity here? If PrEP and non-occupational PEP are only available in 10 out of the 17 regions. How about our fellow citizens who live in geographically isolated and disadvantaged areas? So I like what Dr. Shoshana said, that the context matters. And I'd like, in my group earlier, I pointed out that whatever we do, we need to take care also of the social and commercial determinants of health. Because unless we pay attention to the larger picture, the smaller picture cannot be addressed at all. Let me now switch to some of the key findings that we have. One is that we allow testing of minors. And I asked one of our colleagues who is a lawyer physician, how many lawyer physicians do you actually know? There aren't all that many. I said, can you tell us, will differentiated PrEP by trained volunteers be allowed? Are they violating any rules? Is task sharing going to be a problem? And he said, no, ma'am, because PrEP is not a medicine per se. It is a prophylactic which we give. And he also used the analogy of just like having vitamins. So he said that theoretically, no, but we should also be prepared for pushback. When I talk to healthcare workers, if they do prescribe PEP and PEP, and they said, PEP, no, because there are no guidelines. PrEP, only if you do all the clearance exams, creatinine and whatever exams you want. And then I asked them why. They say that we have our license to protect. We also want to make sure that we do no harm. So we have still a lot of advocacy to do with our own community of healthcare providers. And let us be honest also, our pool of trained healthcare workers and counselors and volunteers is diminishing. We're getting tired, we're getting old, we're getting pirated by rich countries. We're losing our nurses, we're losing our our barangay health workers, our village health workers. So there needs also to be continuous training and capacity building at all levels of the healthcare system. The lovely volunteers, for example, of LoveYourself, when they reach a certain age of maturity, might not be as enthusiastic as they are right now. And that's a fact of life. So we need to have a constant pool of people who will still be engaged with us. The issue here of equity is one which is dear to all of our hearts, because how can we say that it's a life-saving product if it only reaches so many people and with great difficulty? So task sharing is possible, it's legal, doesn't require a written prescription by a licensed healthcare professional. Another problem is the supply. It's donor-driven, donor-funded, donor everything. Where is the Philippine government standing up to supply its own people with much-needed supply of PrEP and PEP? I also said this in our meeting last week with the commissioning agency, and I said, let us not pretend that government is an expert in supply chain management. We have excess drugs in Health Center A, but we lack drugs in Health Center letter X because we are imperfect in supply chain management and demand planning. And my classic example is always from the work of my husband and my son. They both work in multinational corporations. My husband used to sell soft drinks in bottles. He knows when the soft drink in sari-sari store of Aling Maria in an island is already consumed, and the soft drink bottles, the empty ones, need to be picked up, brought to the factory, cleaned, filled up again with the product, and then brought back again to that village store in an island. He also knows exactly where his salesperson is at 3:05 on a Thursday afternoon because they're all on GPS. So why can't we use the models from the private sector? If bringing soft drinks is, for me, it's a non-essential, but anyway, it supported my family, so it is essential. Of course, like Manix would say, again, that's a non-essential good. And yet we can deliver it perfectly. And people are happy with the product and the service. So those are also food for thought. Let us not pretend that we're champions and experts in supply chain management. Government will never be an expert in supply chain management and demand planning. The other thing I also notice is the language that we use. I said earlier in the group, we said bababa sa community, meaning going down to the community. And I called the attention of everybody. That is not the language of collaboration. That is the language of patronage. That we are seated here on the stage, and you guys are down there. And when I go down there, I am actually higher than you. So if we engage with communities and want communities to be real partners, whatever community it is, whatever agency it is, it has to be a language of collaboration. And I do not like the term bababa sa community. Go down to the community as if we are higher and they are lower. So these are just some of the points beyond the policy brief that we prepared also with Dan Vic's involvement too. Financing. How can we finance a largely donor-driven product? And we also commissioned a consultant with us. He's a health policy economics expert who's also a physician. And he said, ma'am, we have a Philippine Pharmaceutical Corporation, which is the only government controlled corporation allowed to import pharmaceuticals and sell it at a negotiated price to the local government units. So we can actually have pooled procurement because the local government units are scared of pooled procurement. They also don't think that PrEP and PEP and HIV are priorities. So that's also a problem. So we need to advocate to those who hold the power of the purse. Convince our mayors, convince our village captains, convince our senators. I have heard the President and the current Secretary of Health say that HIV/AIDS is a priority, but I don't see any real action on it. It's wonderful to hear every December 1st, for good sound bites, but I really haven't seen action. We were originally commissioned to develop policy recommendations for the Ministry of Health. When we had our kickoff meeting, they said, no, we will be the ones to formulate the policy. So what are we supposed to do? Yours are just recommendatory. I said, fine, no problem. But I was just told today, I was asking with Doc Louie, no recommendations yet for updating of the current policy for PrEP, and no new recommendations for non-PEP, non-occupational PEP are in the pipeline. So Doc Louie was talking to me earlier, can we convince you to actually help us write it? I said, okay. After being told, no, you aren't supposed to write it, now I think they realize that it's a lot of work. So we always need to be open to the collaboration. It may not always be smooth, but we're willing to listen and to learn. And we've heard the demands of the healthcare workers, the trained volunteers. We've also heard the voices of our patients. We've also heard the voices of communities. But again, the policymakers, we need to convince them that it is indeed important and that prevention through PEP and non-occupational PEP is a worthwhile investment. And let us stop depending on foreign funding for our own needs. Thank you.
Thank you so much, Doc Nina, for sharing your insights in your personal capacity. Linawin lang po natin. Yeah, to sharing your insights because these are very, very important insights. And as you said, it's very important to share the voices of, especially the people who are already doing PrEP, despite our guidelines are not yet that fit in, in differentiation. And it needs an overhaul to accommodate our innovations and our best practices. And speaking of best practices, this is what I would want to hear from our representatives. But I would start first with Ma'am Almira, because knowing that your region is very diverse, but you have been rolling out PrEP for some time now, and it is actually an accomplishment comparing to other regions where there's still struggles and problems in terms of how do they roll out PrEP in their respective localities. Can you please share your experience in your rollout of PrEP in your region and any challenges in your rollout that you want to highlight in this room?
Thank you. Once again, I'm Almira Sulaiman. I am from CHD Soxargen Region, Region 12. So it's been a year since we launched or we implemented PrEP in our region. We started I think in February and March, or I think in February or March in 2023. Actually, we have a total of 350 PrEP enrollees since the time we started until yesterday. We gathered the data from the different facilities. So we are implementing 10 out of 11 HIV treatment facilities that were trained on providing PrEP services. This might be smaller compared to the other regions that have been providing PrEP as well. However, for our region, we are, like what you said, it is culturally very diverse. We are mainly consist of Tibolis, Blaans, Manobos, and Magindanaons, and we also have other, let's say, Ilonggos and Visayas. But considering this number, this might be smaller compared to the other regions, but 350 number of enrollees from the last year that we started is already an accomplishment for us. So as we all know, maybe in our region, HIV itself is a taboo. Even the LGBTQI, the community is already a taboo. So accomplishing that large number is a big accomplishment for us. Sharing our experience in preparation to our rollout, we conducted or we capacitated our physicians, nurses, and other members of the HIV/AIDS core team in our HIV treatment facilities by conducting an integrated self-testing and pre-exposure prophylaxis training. This was funded by the Filipina Cell Foundation Protects Project, headed by Doc Lloyd. And we also invited experts or resource speakers from the LoveYourself. So with the help of Doc Migs and Jess, so they're the resource speakers that we invited to roll out or to conduct the training. for us. So that was December 2022, and by the time that the PrEP was already provided to the region in like February or March in 2023, our physicians or the core team is already capacitated or trained on how to handle and offer the PrEP in our facility. For the other question, I think you have the follow-up question. Yeah, any challenges? I think the same with the other challenges, same with the challenges that the other facilities or regions have been experiencing, no? One of the challenges that we encountered is that we had a hard time sustaining the number or adherence of these number of enrollees. So we have 350 enrollees, but as to the number of retained PrEP availers, we don't know the exact number yet, no. Second one is these individuals have the lack of perception, or even the sexually active individuals have the lack of perception of them contracting HIV. So even though they know that they are sexually active, they are in the denial stage, and they do not want to take the PrEP, no, even if it is already provided in the region. So that's one. I remember during the PrEP Summit last year in February 2023, I guess, one of the topics or the reasons why we have low incidence or low enrollees for the entire Philippines for PrEP is the number one is the lack of accessibility of individuals. So that's what one thing that pushed us to establish PrEP in our region. But even though we have 10 out of 11 HIV treatment facilities providing PrEP, there are still some individuals, even the non-reactive individuals but are sexually active, or those who have high risk of, or those who have high risk behaviors, they still refuse to take pre-exposure prophylaxis as of today.
Thank you so much for sharing your experience. I think the 350 is not a small number. It is a great number in terms of, making people na mas protektado sila against HIV, and it's a really, really good accomplishment that needs to be applauded. So it's really, really a good accomplishment. And I think I'll just borrow keywords from Doc Lloyd every time he says this, that, just build the service and people will come, diba? So I think and I think I'll go back to that service where, when we try to offer this service to our clients, and I would want to ask this question, and anyone from the group can answer. Because I think in our line of practice, when people access the service, our clients access the service, usually clients have concerns on accessing PrEP. Even though it's already accessible, even though they knew that PrEP is already accessible, they have concerns of that somehow limits them to access PrEP. I think from your experience, can you share what are the usual questions when they ask for PrEP? What are their usual concerns, and how do you usually respond to them? So I'll start off with either Johan or Marvin.
Thank you. So hi everyone, my name is Johan. I just wanted to give a little bit of background so we have the full context in mind. In 2021, HASH was tapped as a nonprofit and community-based organization to help make PrEP more accessible to Filipinos. At that time, as I was serving as social media and communications head of that organization, the number one question that we usually got from clients was, what is PrEP and what does it really do? So we addressed these questions with several initiatives, one-on-one conversations, both online and offline, via our volunteers, CBS motivators. We did webinars. We also did pop-up mobilizations, among other things. Fast forward to around present day, we saw a little bit of a shift when it comes to the questions that we receive online and offline. We get more questions about how to avail, HM, how much po. So it's very Filipino, if you will, online. And this is very Filipino because we want to get the practicalities out of the way. Once we get the practicalities out of the way, the next questions that we usually get are about side effects. And then after side effects, the next question that we usually get is about how to use PrEP properly. So again, once you get the practicalities out of the way, their number one concerns are as regards health and as regards proper use. Another way that we address these questions is through the use of motivational counseling. We make each and every conversation personal to the individual in front of us, because the more you connect with this person, the more you are able to convert them from just a client or a consumer to an advocate and a referral point for your services as well. But more on that later.
Hi, I'm Marvin Natural from MediPri Medical Clinic. We're a private clinic based in Cainta, Rizal, but we're also a primary HIV treatment center. Okay, so most of the questions that we have, I'm a clinician, so they would come to me for HIV testing or to start PrEP. As Johan said earlier, the questions before were what's PrEP, how does it work, and then it shifted to how much, because we're a private clinic, some of the services regarding PrEP will not be free, but the medication is free. And then questions about how to use it properly and the implications of not using it properly. Those are most of the questions that I ask, that the clients ask from me. And one more glaring question is the use of condoms with PrEP. Is PrEP still, is condom use still needed when you're already on PrEP? And then this conversation leads to more questions about what the client's relationship is with condom use and pleasure, and the implications of wanting to protect yourself and enjoying sex at the same time.
So thank you, Marvin, for opening that topic, because we know that most of the people who would want to access PrEP are actually sexually active. And as a provider, as a doctor, how do you facilitate discussions about sexual pleasure, and how do you combine it with your overall management of your sexual health?
Yes, that's a very relevant question, especially when I got exposed. I'm fairly new as a clinician in the advocacy, but I've been in the advocacy for almost a decade, more than a decade now. But when I got to interact with the physicians involved in the advocacy, not all of them are what I had in mind. Like, they're mostly elderly women who probably do not know much about how MSMs seek sex, what the sexual practices are, all of the elements involved revolving around sexuality of men who have sex with men. And that becomes a barrier, especially as clinicians, because we have to have an open mind when we interact with our patients. And we can't all be MSMs who take PrEP, who see these patients. But we have to set aside our own biases and understand our client more. That's how you build a connection, a rapport with your clients, and get the information that you need about the sexuality, the sexual pleasure, and how you can reduce risk for that client. For me, my approach is to approach each client like it's a general consultation. Like I do history, which involves comorbidities, sexual history as well, STIs, and it just becomes part of the whole consultation. And when the Filipinos are very much when it comes to doctor-patient relationship, there's still a paternalistic relationship. Although we want to shy away from that, it's still present. So they become more open when you're asking these questions, as if this is just part of the process. And then when they're starting to open up, then you ask, you get more information about their sexual practices, their use of condoms, their number of sexual partners, the sexual acts that they do, and if they had previous STIs that you need to address then. Then it becomes a partnership, and then you have you make a decision to reduce the risk. And then the conversation about PrEP begins, the use of condoms, if it's negotiate condom use. But we have to be aware that not all people will use condoms. That's why we have this problem in the first place. Not all people are comfortable for one reason or another to use condoms. And then you have that conversation and you can jointly make that decision to reduce risk.
Thank you so much. Johan, anything you would want to add with that question? How do you facilitate discussions about sex, sexual pleasure, and management of sexual health, especially with your clients?
That's a very good question, and I just like to add, or rather emphasize or highlight what Doc Marvin said about having these personal connections with your clients. That's very, very important because sometimes we default to our trainings as professionals, but we have to remember that these are individuals with very storied lives behind them. And if you start from there, the more you get to know them, the more you'll be able to help them eventually.
Yeah. Yes, Dr. Nina.
This morning we talked about stigma, but we also talked about pleasure. One of my classmates in sociology is now teaching metaphysics in a theology seminary. And I said, okay, what is metaphysics? And he said, the chair only exists if you say it exists. Okay, sige. So pleasure is something like that too. It's something very personal definition, and if you say it exists, it does exist. But if I use a sensorial stimulus, going back again, I'll push a pin into Dr. Natural's arm versus stroking his arm, then they can already distinguish between pain and comfort or something soothing or pleasurable.
And that's very interesting, especially some of these questions talaga, when we encounter them, it really comes from communities, especially when we talk about them. And I think I'll focus more on the community aspect of of offering the service. And I think Johan, you as member of a community-based organization, you have the experience in talking to communities, reaching out to them, and offering the service to clients. So when we offer PrEP, we are not just helping the health system, but we are actually the architects of the PrEP service delivery in the Philippines. How do we enhance further this community engagement? Paano natin mas mapapalawig pa yung pagbigay natin as community ng PrEP sa ating mga communities?
That's great. And it's a very deceptively complex question that could be answered in many different ways. But from my end, I'd like to highlight 3 different levels. On the level of the individual or on the level of service providers, again, sirang plaka na po ako dito, but let's make our conversations personal with each individual. We see that having personal conversations enables these clients or consumers to have personal conversations of their own outside of the providers. And word of mouth is very powerful, and it starts with an honest and personal conversation between the provider and the client. On the second level, on the level of organizations, perhaps we could improve our skills in connection with social and behavioral change communication with due regard to the social and commercial determinants of health, as Doc mentioned earlier, or just ground up cause-based marketing, especially digital marketing in general. These are tools that will help you better connect with the many different communities that you see. We've seen how influencers and key opinion leaders have shifted markets and have concretely gotten people on PrEP. Recently, we've seen the power of user-generated content, which is a term or an indicator rather, in the digital marketing world, whereby you see that you have successfully converted someone as an ally or as an advocate or as a referral point. Lastly, we should continue empowering community-based organizations through means like microgrants or anything that you could really extend to these organizations. Why CBOs? CBOs are woven intimately into the fabric of the communities in which they serve. CBOs are intimately acquainted with the struggles, hopes, and aspirations of the very people themselves. If we allow them, as Danvik mentioned, to be the architects of change within their own contexts. We can make positive ripples of change, as Love Yourself likes to say. And the last thing that I'd like to remind everyone, I guess, is we should look at PrEP as not just a pill, but a promise for a future where we are free to love unconditionally.
Thank you, well said, Johan. And I would like to invite the audience to join into our conversation and ask questions. So we will try to view some of the questions that was already asked by our audience. So the first question is, for the service providers in the plenary, how many amongst you provides non-occupational PEP? If there are any, do you proactively transition to PrEP after the PEP regimen? So let's try to ask the plenary actually. How many here are already providing non-occupational post-exposure prophylaxis? Please raise your hands. Be proud. Konti lang po tayo. Ayan. Be proud. Ayan. Yan. Tayo lang po nagpo-provide ng non-occupational PEP. So I think, is anyone from the panel already providing PEP? Is Hash providing PEP?
Yes, through the help of our funders and supporters and partner healthcare professionals.
How about MediPrime?
Yes, we do provide paid PrEP.
Paid PEP. Okay, PEP. Okay, sige. So, I think I'll throw in the question first to those here in the stage and for the plenary later. For those people na nakakuha ng non-occupational PEP, do you proactively transition them to PrEP?
For Hash, yes, we do. We pay particular attention to the continuum of care that the client may experience. So it's not just a single point of transaction whereby they get PEP. We try and provide as many services as we can. Actually, it's interesting that the question was posed this early in the conversation, as I'd like to highlight how PEP is so inaccessible here in the Philippines. A lot of the PEP providers are in Metro Manila. In the provinces, we rarely hear of PEP. There are stories. Do we have the time for these stories?
Yeah,
Okay.
I think it's the discussion is very relevant because I'm sure in our community, the clamor of requesting for non-occupational PEP, lumalakas siya. And I think if we can share some insights of the communities of their need, why do you think that non-occupational PEP is actually very relevant to the HIV service delivery?
Great, thank you for confirming. So I have two stories to tell. First is of an influencer based in the province who was out on vacation in Boracay. So they had an encounter and they realized that they might be eligible for PEP. So they messaged us online asking for this intervention in the middle of the night. And then we had a discussion with him. We found that he was almost done with the period for post-exposure prophylaxis. So we coordinated and we asked this person if they could fly out to Metro Manila. Fortunately, they were affluent enough to do so. And we sent a team to meet them at the airport just so that they could fall well within the 72-hour window period. This is someone very affluent, someone with resources. If it were a regular Filipino on a very tight travel budget, this would not be possible. The second story that I'd like to tell is about this student in Baguio, which is just 6 hours approximately from this location. The student also had an encounter. It involved violence, unfortunately. They reached out, and at the time, there were no post-exposure prophylaxis providers in their area, or at least none that we could contact directly so that we could provide this service. So we had to get creative. We befriended a bus conductor out of all people to become a sort of courier for us. So all they knew was that they had a parcel that someone would intercept at the moment that they arrived at the bus station in Baguio. So two things that I'd like to highlight here. Both the affluent and people without resources are affected by the inaccessibility of post-exposure prophylaxis. And this is something that we have to seriously consider at our level where the decisions are made.
Agree. And actually to add another story, I remember this was actually just happened last week from our Love Yourself hotlines where someone called and he said, searching online, called our PrEP hotline and asked for PEP. And when we asked the need of why he would want to access PEP, he said that he was sexually abused. So that necessitated us to really, provide an emergency way for him to access PEP. And it's not only PEP now that we will manage to him. Kasi dahil nga may sexual abuse, it would involve a lot more conversations. And I think somehow this places people at risk, 'di ba? Na minsan hindi naman nila din kasalanan na nalalagay sila sa risk. And I think that is relevant to the next question that I'm seeing now. What will be your stand on those people who doesn't care their social responsibility on taking PrEP and still doing risky behavior? And what is your stand to engage those key populations like women, sex workers who want to avail the PrEP? Anyone from the panel can answer?
Okay, maybe I can answer on the second question. What your stand to engage those KP like women sex workers who want to avail the PrEP? So actually, this is a dilemma, no? We are actually offering PrEP mostly to our KPs, the MSM, the transgenders, those who are sexually active. But for the female sex workers, we have a lot of female sex workers who are interested in availing PrEP, and that is the dilemma. No, we would like to expand the provision of this service to the female sex workers as well. So that is my stand in my region, since a lot of sex workers have already been asking if they can also avail since they are sexually active, no?
How about for the others?
Okay, for the first question, one of the things that I do when someone comes in asking to be tested or asking to be initiated in PrEP is that I commend them for taking the steps to be responsible enough to protect them and their partners. So this is a bit confusing to me because taking PrEP in itself is a form of social responsibility. You know that you will be doing risky behavior, but you took the extra steps to protect yourself. It may not be 100% safe, but it's safer. So that's why we need not to antagonize our patients, our clients, for their sexual practices. That becomes another discussion on how to reduce the risk that they put themselves in.
Any other insights that you would want to add? Yes, Doc Nina.
The second question, when I attended the PrEP Summit last year, I actually voiced that question also. And because I've heard it from the women, bakit pang, quote-unquote, politically incorrect, bakit pang bakla lang ba yung PrEP? Yun ang tinanong sa akin ng mga commercial sex workers, no? Why is it only for MSMs? What about us? We're at risk. And we know the risk, and yet we do the profession that we're engaged in because we need to earn our living. I think this is also a challenge for all of the funding agencies here, including that guy there, Lloyd. There's so many artificial eligibilities that we have put in by virtue of the funding sources. So it's the funding agencies who have declared, our supply should only from MSM, TGW. But in the real world, everybody should be eligible if they pass through our screening and they have a need for it. So that's also the challenge for funding agencies who drive so much of our healthcare agenda also and create artificial eligibilities, which are also unethical in terms of access. You're now limiting access. The female commercial sex worker is probably the person who needs PrEP the most among all of the different eligible populations that we have identified. So I think it's also a challenge for those of you who work for donor-funded projects can we actually expand our coverage for anyone who actually expresses interest and are clinically all right to receive it, etc. They're not pregnant and whatever. So that's a question, I think, for each of us to think about.
Thank you, Doc Nina, for your answer. I
Hello?
saw some hands raised.
Danovic?
Yes, Shoshana. You want to?
Hi.
Yes.
Yeah, so I just want to quickly come here and just to remind ourselves, again, going back to the guidelines on few things. First is that, just to say that from 2015 onwards, we know that PrEP can be offered to all those who are at substantial risk for HIV. Now, what happened is that, of all the criterias, then evolved a risk-based criteria. And you may remember that, we had those criterias, what is your risk? And if you only follow, come into any of those risk profiles, any of you have those risk, quote unquote, that risk behaviors, you say you have it, then only you become eligible and then you go for those, then of course the testing, HIV testing and all of the other criterias. Now, one of the things which I had actually not mentioned during my presentation has happened is that, and that's a revised implementation tool for service providers will be released soon. That's in the pipeline. It will be coming up this year. And many of you have seen that this implementation tool was already there in 2017. Now that has been revised now. And one of the things that they have done in the implementation tool is to actually say that first and foremost criteria that who should be offered PrEP is the person who is coming and asking for PrEP. Because asking for PrEP shows that the person is at risk for HIV. And even if I don't disclose my risk behavior or my risk profile, but I'm still eligible for it because, I think I am at risk. So that's the change that has happened. That's one thing and you will get to see the implementation tool pretty soon. And the second thing I also forgot to mention, because the conversation came around female sex workers, that Philippines is also one of the 4 countries where a feasibility and an acceptability study of DVR has been undertaken. Philippines has not started the study, but it's going to start very soon. 2 other countries which have already completed, the Cambodia and Indonesia. And one of the things what we have seen, in this study from the other countries, just broadly speaking, it's coming up that this is, coming up as a possible option for the women who are at substantial risk, which includes entertainment workers or sex workers or women partners of people who are living with HIV or women, sometimes the female partners, of MSM. So various groups of women have been interviewed in the countries and they are talking about their acceptance about DVR. So these are the 2 things I thought I will share with you.
Thank you so much, Shoshana, for that input.